Hi everyone. Maybe we will just get started in the interests of time, and hopefully our experts can join us shortly. So thank you all for coming today's in our actually first series for both North and Southwest London joint cancer webinar, and today we're going to be talking about our hot topics. So if we could just go on to our holding slide. Here we go. Yeah, so thank you very much, everybody. And so my name's Abjit Gill. I'm the Northwest London Primary Care Clinical Director for RM Partners for cancer, and I'm really pleased today that I've got a couple of people joining me. I know I can see Maria. Maria, would you like to jump on and introduce yourself?
There we go, just managed to unmute myself. I'm Maria Wallace, I'm a GP in Putney, and I'm the Wandsworth Cancer Clinical Lead.
Amazing, thank you, Maria. And I'm just waiting for Hassan, but I will just let you know that Hassan Kazi is a consultant urologist, and he's the prostate lead for St George's. He's probably very well known in Southwest London, and also here in Northwest as well. He's the urology pathway chair for RM Partners Cancer Alliance for West London. So just a bit of housekeeping, really. I mean, we say this every time, so if we could just ensure that everybody's muted and to avoid any background noise, and so that we could keep our bandwidth, switching of videos off is helpful. You'll see a series of buttons on the top of your screen. I'm sure you know how to use those, and we'll be using the chat function as the main way to ask questions and to interact with some of the case studies, so please keep an eye on those, and we'll be manning that chat function too. And we'll be recording the webinar, of course, and making sure that that's going to be circulated appropriately through the comms team, the training hubs and stuff. So feel free to ask questions and try and make this as interactive as possible. And at the end, which is really helpful for us, is we'll be sending out an evaluation link, and that will be in the chat box as well. And so please do kind of fill that out. So we just want to check if Stevie, do you know if Hassan's joined us yet?
He's just arrived.
I have. I've joined you. Sorry, my Wi-Fi had died at the hospital.
No, not at all. Well, thank you so much for joining. And I think just before you came, I've just gave a little bit of background of yourself, and so hopefully I've introduced you appropriately. But what I might do is skip through to your slides and to talk about, hand over to you to prostate cancer, about prostate cancer.
Thank you, Abs. And Stevie's got slides going through. So thank you very much for joining, everybody. I'm Hassan Ghazi. I'm the consultant urologist today. Now, there's been a lot of publicity, etc., about prostate cancer, and I'm sure you guys are seeing a lot of this as well. There has never been a study which has demonstrated the benefit of screening men for prostate cancer, and that is because the definition of screening is to not do targeted screening. With our heterogeneous population, especially in the London area, if we were to do a study with a high ethnic minority background or high BAME population, chances are the results would be different. In essence, 1 in 8 white men and 1 in 4 black men in the course of their lives will have a diagnosis of prostate cancer. And our real plan is to develop and implement a plan to increase the proactive and opportunistic assessments of patients for potential cancer diagnosis in population cohorts where referral rates have not recovered to the pre-pandemic baseline. We are still missing some people who may have been treated during the course of the pandemic. So it is quite important that in the course of our daily practice, we are aware that some men are at a higher risk. And those essentially are men over the age of 50. And as we'll go on, there are some very specific risk factors going ahead. Next slide, please. Now, thank you. I've got a couple of case studies, and I'd be interested in your thoughts. So the first is an 83-year-old white male without a family history of prostate cancer presents to your surgery, and his main complaint is that he's been going to the toilet twice at night time. His urine dipstick is negative, and his past medical history includes ischemic heart disease, CKD3, he's got non-insulin dependent diabetes, and he's got COPD. How many people in the audience would consider a PSA at this early sort of stage? So 83-year-old man with significant comorbidities presents with nocturia as the predominant symptom, right? We've thank you. That's really interesting, right? So the current guidance regarding PSA is as follows. So PSA should be checked in the context of 3 different things. The first is if somebody has urinary symptoms, then PSA should be checked. And that is because the larger your prostate gland, the more PSA you produce. So if your PSA is over 1.3 and you present with urinary symptoms, chances are that tamsulosin monotherapy will not be enough. You will need finasteride as well to try to shrink the prostate gland, because people with a PSA of over 1.3 and LUTs tend to have larger prostates. The second one obviously is if you are suspecting prostate cancer and someone's DRE is abnormal. And the third one is that if someone is on testosterone supplementation and you are going to keep an eye on their prostate cancer risk. So, and that's why I put this up, because first of all, PSA, would you check the PSA if the patient had not had symptoms? And the answer would have been, no, I wouldn't have done, because he seems to be an 83-year-old man with significant comorbidities, and checking a PSA as one of those things would probably generate a diagnosis of incidental prostate cancer, which would not be relevant and would not be life-limiting. So this gentleman does not seem to have an expected lifespan of 10 years. However, in his case, in the context of urinary symptoms, yes, one could check a PSA. I said nocturia into 2, and that is because if the gentleman does not have any daytime urinary symptoms and his only complaint is waking up at nighttime, chances are, and this is based on a lot of studies looking at nocturia, he's either got a disturbed night's sleep, or for various reasons, he's got nocturnal polyuria, so selective nighttime symptoms, which is just waking up twice at night in the absence of daytime symptoms. You could even ignore the PSA because he doesn't have LUTs, which are daytime and nighttime. Would you do a digital rectal examination? Again, the answer is you may do it, but at the same time, if his main problem is nocturia into 2, you could do a DRE to assess the size of the prostate or whether he's got significant disease. But in this case, I don't believe a DRE is absolutely mandatory either. So this was a slightly contentious scenario where there are pros and cons for either. But just to summarize, that anybody presenting in the absence of symptoms who has a low risk profile does not need his PSA checked, especially if they've got comorbidities. Now, the second scenario is 55-year-old Caribbean Black gentleman with non-insulin dependent diabetes. His brother developed prostate cancer, and he presents with urinary frequency and urgency, which he initially attributed to his diabetes. His urine has a bit of glucose. I suspect his HbA1c is not ideal. And his PSA has risen from a value of 0.9 to 3.1. Now, the first is if you saw this gentleman with that history and you had that PSA, would a remote consultation be appropriate? Is that something you would consider doing, or would you call every single patient in? So we are saying that he's got an elevated age-specific PSA. Remotely. Should we vote on that? Thank you. And the second question is, so his PSA is elevated and he does not have a urinary tract infection. You've checked his blood tests. Would you call him back for a DRE? So what percentage of people would, you've not seen him up front, and do you need to see him back for a DRE based on PSA? Okay, that's again really interesting. So First of all, in this day and age, I think that remote consultation is perfectly appropriate, but of course you are in the best position, and obviously it depends on whether the gentleman is able to assimilate that information, and we'll go on to the various issues we've had with telephone consults, etc. And the message is that if somebody's age-specific PSA is elevated and they don't have an obvious plausible explanation, this gentleman is high risk. So in a Black Caribbean male with a first relative who's had prostate cancer, he has a 1 in 2 lifetime risk of developing prostate cancer. So obviously he should have had his PSA checked, and we've dealt with it proactively. And the second is, if the PSA is elevated, you do not need to see them back for a DRE because they should be referred straight to hospital. So the criteria for referral obviously have been that if you do a DRE on somebody who's got an abnormal feeling prostate gland, even if the PSA is normal, you can refer them in, because a very slim minority, the figure was 1 in 7, it's probably lower now, a small number of people can have prostate cancer with a normal PSA. And the second is, with an elevated PSA, it would not impact your management, even if the DRE was entirely normal. We know that it is not very sensitive, and also a quarter of prostate cancers happen in the front part of the prostate gland, and however good your DRE, you will not be able to pick that up. So any urologist being sticky about a DRE probably need a little bit of education from our perspective, because that is not expected with an elevated PSA in this day and age. Next slide, please.
I think this is myself and then Maria before we hand back to you, Hassan. So really just putting in context what Hassan's just said is really, really helpful, because it brings everything together from the PCN DES. Now, for the PCN early cancer diagnosis DES, you will note the focus on prostate cancer this year. And one sticking point, a lot of feedback we've had, and part of the reason that we brought this topic here today, was the question of proactive and opportunistic assessment for prostate cancer. And Hassan very kindly just touched on that, and the reasons of which that we really do need to consider this. And so we've quite rightly identified the importance of identifying age, ethnicity, and family history of prostate cancer, and trying to therefore find out those particular patients within our practices and PCNs that are at higher risk of prostate cancer. So we've gone back to the national team, and we've checked in to say, if we have an approach and in proactively assessing these patients, can we identify these lists within our practices locally that meet these high risk patient criteria and try and reach out to them? And we've had that confirmation. So one could create a search to identify these patients that meet all of these risk criteria locally within your PCNs and at practice level. So men over the age of 50, Black Afro-Caribbean, and those with a family history of prostate cancer. And thereafter, invite them in or send a link to the Steve McQueen video, for example. And those of you that haven't seen this video, the link is here. Circulate the slides. Is incredibly powerful and helpful. And that would be an intervention that would meet the PCN DES. Another thing at a system level, at a north and southwest level, that we're trying to do is to create alerts and pop-ups on the home screen of the page within System 1 and EMIS for the same criteria, for that just to pop up at a time that you would open the patient record, so that you can have it in your mind that this patient may be at risk of prostate cancer, and therefore prompt a conversation with them, with the patient at the time. Another thing that you could be doing is to use some of the education leaflets and some of the bits and pieces that we have here, and we'll come on to that within a couple of slides of the resources, and upload some of this information on your practice websites, waiting room display screens, etc., as patients are starting to come in. There is a link down below, a little bit more on prostate cancer with the Northwest London that we've done before in the context of missing first treatments, which may be helpful. Next slides to Maria.
So I'm just going to talk very briefly about a specific initiative that's trying to proactively identify men with a potential diagnosis of prostate cancer in the community. Specifically, this is happening in Southwest London, in Croydon, with a view to moving to Merton in the near future. And it's a pilot by RM Partners. It's called the Man-Ban Project, and it aims to identify at an early stage conditions which, if treatment were delayed, would have a worse outcome. So that's with particular reference to prostate cancer and other urological malignancies. So basically, it's a purpose-built van, and it's manned by an AMP together with the support of an administrator. And they deliver assessments a bit like a well-man check, which focuses on prostate cancer and also general well-being. If the patients are then identified to have an elevated PSA, they're referred directly down the 288 pathway by the service. And also the Man-Ban team are responsible for sharing the results with the patients. So I'm just going to hand back to Hassan now, who's going to talk through the 288 pathway and referrals.
Thank you very much. Next slide, please. So we've been working, obviously, on the referral forms, and I just thought I would take the opportunity to go through the tick boxes and what the rationales are and how it impacts what we do subsequently. So the two red boxes are the ones that we often encounter. I've discussed the possible diagnosis of prostate cancer with the patient. We ran an audit recently where a small number of people, about 1 in 4, were not entirely sure about why they had been referred and what the context of an elevated PSA was. And the other sort of thing, especially with the new faster diagnosis standard, where we are supposed to tell 75% of people within 28 days whether or not they have cancer, is that especially during summer, a lot of people are referred under the 2-week rule, but subsequently, when we do send out appointments, they are not engaging with the system, and they say, well, I'm going to be off for another 4 to 6 weeks, which then, of course, impacts cancer performance. And we are not allowed to take people off the suspected cancer pathway because they are on vacation. And the system, unfortunately, does not allow for very much flexibility. I've had very uncomfortable conversations where it's sometimes been suggested that, you can get patients to be re-referred, etc. So just to say the message that this is suspected cancer and they should prioritize appointments within the next 28 days. The next thing is about renal function, especially. So, of course, PSA, highly important. Even if the prostate feels very abnormal, it does really help us plan upfront investigations. And the reason for the GFR is that the upfront investigation for anyone with suspected prostate cancer will always be an MRI scan, which requires an eGFR. So if we do not have an eGFR at the time of diagnosis, unfortunately, we are quite limited in terms of what we can do. Next slide, please. Thank you. So we won the HSJ Award for Innovation in Healthcare, and this was a joint North and Southwest London project shared with Imperial, George's, and Epsom and St. Helier, where we completely revolutionized the management of suspected prostate cancer. So prior to the project, any patient presenting with suspicion of prostate cancer would be first seen in clinic by someone like myself. They'd have a digital rectal examination. They'd then be told that they required an MRI scan. They'd be seen with the results of the MRI scan, and then depending on that, would be booked for a biopsy, which was often a general anesthetic biopsy. And in West London, we delivered a straight-to-test model. And I work in the Southwest, but this is a network-wide project. And essentially, all the patients who get referred in by yourselves have a daily triage done by a clinician. Now, that ensures that patients have basic investigations such as PSAs, renal function, etc., checked. And also, we try to rule out people who've had a urinary tract infection, because if you do an MRI scan with a recent UTI, it's falsely positive. After we've triaged them, they are contacted by a pathway coordinator, and some people do not have an MRI scan up front, and those are people who've had a symptomatic urinary tract infection, those who've had a urinary retention and have an elevated PSA, people who are claustrophobic, and those who have metalwork in their body cannot have an MRI scan. We've made it a point to not have claustrophobia and metalwork included in the referral forms because you guys are busy enough as it is. So in this day and age of onslaught on general practitioners, that's our responsibility, and we will always have about 6% of people who can't have an MRI scan for various reasons, and we are very happy to work around that and manage them in the best way. We also check their IPSS, so about 40% of men who have an elevated PSA and are referred to us are presented to yourself because they had urinary symptoms. So we've also tried to sort of bring services together where they're not just referred with an elevated PSA, they have an MRI scan, it's negative, and they are discharged back without their urinary symptoms being checked. So we are proactively screening all men for urinary symptoms when they come in. And the one final thing is that initial consultation that happens to tell the patient that, are you claustrophobic? Do you have metalwork? And would you be able to come in to have an MRI scan? And this is what the MRI scan entails, is done on the telephone. So it is quite useful to know if the patient cannot have a telephone consultation, because that then impacts their pathway. Now, most of the patients have an upfront MRI scan, which means that they come in, they fill out an IPSS questionnaire. If they have urinary symptoms, they do a flow and residual. So we assess the function of their urinary tract. Certainly in my service at St. George's, we also check for erectile dysfunction, which is important and has bearings in their subsequent journey. And also they will have an MRI scan, and then they will be seen with the results of the MR. Now, about 1/2 of people who have an MRI scan are discharged because the scan is negative and they have no symptoms. And upon discharge, we are obliged to provide them with a threshold PSA. So for example, a man with a 50 cc prostate gland without any lesions has a threshold PSA of about 7.5. And if someone is at a higher risk and requires annual PSA checks subsequently, we are supposed to specify the timing. It should really be more frequent than annually for the cohort of population in general. And also, we should give a threshold PSA, at which point, if the PSA is crossed, we should see them back. So again, in essence, we triage people clinically, get them an upfront MRI scan, exclude a few people. That initial consultation is done via the telephone. We see them with the results of the MRI scan, often on the same day. Some people will be seen later on that week, and we manage their urinary symptoms if appropriate. And again, if you very kindly provide the information which facilitates an MRI scan and a telephone consultation, it just smoothens their journey when they come in to see us. Next slide, please. Are you taking over again? Lovely. Thank you.
So I think these are some of the resources that we've put together that may help support PCNs and patients in the context of prostate cancer. So we talked about the Steve McQueen video. There's a Prostate Cancer UK checker, which is helpful, and there is the Macmillan top tips for prostate cancer and other resources for health professionals. So please, if you could take some time to have a look at that. So we've come to the end of the first topic in terms of our slides, but we have this opportunity with our expert here. Is there any particular questions that we have from the group, or any issues that we wanted to raise for Hassan? I can't see the chat box because I'm on my phone. Is there any, Maria? Is there anything that's been flagged in particular?
I can see the chat box. Nothing I can see, but in one of the common things that my GP friends ask me often is, what about a urinary tract infection? So with a UTI, we very often see an elevation of the PSA. It is normally not in its hundreds. So if you see a patient who's had a PSA checked, and technically, if someone has a urinary tract infection, we shouldn't be checking their PSA for about 4 to 6 weeks afterwards. But I absolutely appreciate, often if they come into a surgery, diligent practice nurse will obtain a blood test which incorporates PSA or something like that. But if the PSA is elevated, inevitably we will recheck the PSA at about 6 weeks. And very often we see PSAs which are 20, 30, 40, that sort of range. We allow them to settle down to a baseline in about 6 weeks' time, and we recheck them. And if they are still elevated, then we would consider an MRI scan. The slight challenge is that even though the urinary tract infection settles down, MRI scans stay falsely positive for a few months. So it is in that context where someone's had a UTI, the PSA is a bit elevated, and if a rectal exam is entirely normal, then we are reassured and we don't necessarily kickstart the journey of MRI scans early on. And the other thing I would, again, I think from my perspective, the take-home message really is that please just, if you could, be aware that your African Caribbean population with high-risk cancer absolutely need to be checked. This is very significant, and I would strongly encourage to just go through Embarrassed Film. It's a really lovely little 2-minute video which will really bring home that message. And the second message is, if someone's PSA is elevated, please don't bother with the DRE. Very happy to see them up front and take over their investigation subsequently. Thank you.
Those are really helpful take-home messages, and it really kind of draws together some of the messages that we've had in primary care and embeds them within joining up primary and secondary care. So that's really helpful. And I also wonder, at the time at which we do organise a PSA, that we also organise a renal profile, because that may be helpful for our colleagues in secondary care in any onward investigations.
Thanks, Abs. That is music to to a urologist's ears. So interesting, our pathway coordinator spends a fair bit of time calling up patients and getting them to have their renal function checked prior to the upfront MRI scan. And interesting, we do come across quite a few hurdles where patients saying, I'm happy to come in for my scan, but I'll go into my GP surgery for the blood test. And then, of course, sometimes you don't have access to that information. So yes, it is hugely valuable, certainly with cancer waiting times. If we could have that information, goes a very long way. Thank you.
I think that's really something that we can be doing within primary care. We're ordering the blood test anyway, and we want to avoid any extra steps for the patient. So I would certainly encourage my colleagues here on the call to do that and disseminate that information locally. I think there was a question in the chat box just appeared now.
So Dr. Singh has asked, if PSA is slightly elevated in young patients with BPH symptoms less than 55 years old, would you like them to be referred, or would you like us to try medications for BPH and monitor? So I would go by your PSA threshold values. Now, if, for example, a 55-year-old patient's PSA is 3.1, that is elevated for the age-specific range, and he should be referred under the 2-week rule. Now, within the normal PSA is when I meant urinary symptoms, absolutely. So there was a big paper, M-TROPS, it had 3,100 patients, and it followed people with urinary symptoms for 3 years, and they found that people who had a PSA of 1.3 or more had a larger prostate gland generally, because the larger the prostate, the more the functioning parenchyma and the more the PSA. So within that normal PSA range, if your PSA is 0.6, for example, chances are you've got a small, tight prostate, and just alpha blocker, tamsulosin monotherapy would be enough to relax the prostate gland and to help with the urinary symptoms. If within that normal range, the PSA is over 1.3, chances are you need tamsulosin and finasteride, because your prostate gland is not just tight, it's probably enlarged. So, please feel free to manage people with LUTS within normal PSAs expectantly. And the other practical ramification is, once the PSA goes up, obviously it won't go down. And if you refer them in and they have one upfront MRI scan, we can at least then furnish you with a PSA threshold, so that for the rest of their lives, they aren't in that gray zone of dubiety. So long way of saying, if the PSA is even slightly elevated in a young man, yes, they should be referred under the 2-week rule. If it is within the normal limits, then the magic value is 1.3. If they've got urinary symptoms, tamsulosin monotherapy for lower PSAs, tamsulosin and finasteride for higher PSAs. Thank you. I can't see any further questions.
Brilliant. Well, that's really helpful. And I just have one small question, I guess, for myself. And within the RDEX, the non-site specific RDCs, sometimes we've come across diagnosis of prostate cancer in a context of metastatic prostate cancer, where they've presented with vague symptoms, weight loss, back pain, etc. And part of our filter function tests is we encourage GPs to do a PSA before they send to us. Do you find the absence of lower urinary tract symptoms as sometimes a presenting feature, and is the number of patients that come in with back pain and weight loss and some of these vague symptoms, do they tend to feature in your clinics, or do you tend to have the more classical cases?
Thanks. So that's an amazing question, and thank you for highlighting this. First of all, we know that prostate cancer has no link unequivocally with urinary symptoms. Urinary symptoms occur in men because of benign prostatic enlargement. Now, if within that enlarged prostate gland there is some prostate cancer, then yes, men would present with urinary symptoms. So urinary symptoms are normally a very useful conduit of patients presenting to us, who will then have their PSA checked in that context and be diagnosed. So, and I've, as somebody who's advised Prostate Cancer UK quite a lot, I've been quite equivocal that they should take down billboards which say, you are at risk of prostate cancer if you have lots. That's not true. Prostate cancer causes urinary symptoms when it invades the bladder, which is stage 4 disease, or the sphincter, which is stage 3 disease. So yes, locally advanced prostate cancer presents with urinary symptoms. So if someone comes with urinary symptoms, you will check their PSA generally anyway. And one of the merits in doing a DRE is that sometimes you'll pick up very advanced, aggressive, horrible prostate cancer. But again, that would have been picked up in the context of your PSA anyway. And yes, we find less than 10% of people are still diagnosed at that stage with metastatic disease. But generally, in our clinics, we find that, for example, non-specific weight loss is another common one. But you would get weight loss if you have significant or metastatic prostate cancer, which wouldn't just cause a very modest elevation in the PSA. So the PSA would tend to be in the hundreds or, significantly elevated. And the one final thing that people often say is that, what if my patient's PSA is negative? The sort of patient who will have a negative or very normal PSA and prostate cancer will be somebody with very aggressive, very poorly differentiated prostate cancer, where the cancer doesn't even resemble prostate anymore. It's so undifferentiated, it doesn't produce PSA. And so those people will unfortunately sometimes present with metastatic disease, and on DRE will have a prostate that is so abnormal that even if you do a DRE a year, you will pick it up. It'll be absolutely hard, nodular, really horrible. So just to reassure you that you are safe if you do a DRE and that feels benign and the PSA is negative, then you are absolutely safe. Or if the PSA is negative and you didn't refer someone, you will never get into trouble. I do medical legal case reports as well, because common things are common. Negative PSA still means no prostate cancer unless proven otherwise. Thank you.
Thank you so much. I think that's incredibly helpful, and thank you so much for your time today, Hassan. We've learned a lot, and we will circulate the slides. There's been there are a few comments within the chat box. So thank you once again. And I think what we'll do is we'll move on to the second part of this talk, and we're going to be talking about quantitative fit tests and colorectal cancer. So next slide, please. We can move on to the next slide. Great. So part of the context of bringing this back here to North and South West London is also within the guidance of the early cancer diagnosis PCN DARES, and then the IIF indicator, which is stated within this box as above, which has come for 22-23, and where we're looking at the percentage of the lower GI 2-week wait fast track referrals that have an accompanying fit test. And we know that it's going to be either 7 days leading up to the referral or the 14 days after the referral. And with the caveat that locally we've always had this conversation that fit tests done prior to referral are far more helpful in our secondary care colleagues making decisions within the straight to test clinics about what the most appropriate investigation is, and we'll come on to that in a bit. So we're going to now talk about the 2-week wait referral form and the pathway. So next slide, please. And yeah, here we go. So we've got the 2-week wait referral form, and we're all very familiar with this. And just very quickly to recap, the red flag symptoms for this site-specific pathway, so for the lower GI pathway, are stated within the top right, and so abdominal mass, rectal bleeding, change in bowel habit, etc. But within this, with these patients that have these symptoms should be referred urgently if they have a fit test of 10 or more. Otherwise, if they've got a rectal or anal mass or ulceration, they do not need a fit test, and you can refer these patients without a fit. And otherwise, if there is a fit less than 10 and you've got concerns and you're worried about a colorectal cancer specifically, as a clinician, you can still refer down this pathway, but it's incredibly helpful for our colleagues if you justify that with the additional clinical information. And what we would like to do is also just provide a little bit of reassurance about a fit less than 10 pathway as well in some of the next few slides. So I guess on the next slide, we have just, I guess, recap this slightly. And what may be helpful as an action to take is that all practices should ensure that they have enough fit kits. And sometimes we've had some feedback to say, well, we've run out of fit tests, and the pathway there is set up. Your local surgery should have that link in for the supply network. But if you feel that is something that applies to you, please do just assess this locally and make sure that you have enough kits that if it does drop to less than 25, it's advisable to order more. And so just make sure that you have that process in place. Next slide, please. So here, this is quite helpful. It's a new publication and guidance that was released on the 21st of June earlier this year, and it was published by the British Society of Gastroenterology and then the Association of Coloproctology, with a huge acronym there, which I'm not going to bother to talk through. But sorry,
did we lose you a minute there?
No idea what happened. I was told I was removed from the meeting. So how far did I get, Maria? I was talking.
You got up to the large acronym, so we didn't lose you for long.
Large acronym, and then I left. Okay, brilliant. And so I was so here we go. So we've got this guidance that was released, and that was released on the 21st of June, and it's quite helpful because it kind of tells us pretty much things that we know already, but it helps us kind of firm this up a little bit. And so we know that fit should be used within primary care, and it states that the fit test should be used in primary care, and it helps us prioritize those patients at a higher risk for colorectal cancer to refer those down that 2-week wait pathway for urgent investigations. What's really important is that those patients without a fit result, we need to encourage those individuals to return the sample if it's been lost or inadequately submitted, or if there's a problem within the lab, or it's just not been done because you're worried about that patient, and so that there should be safety netting procedures that we have within those and tracking those patients. If a fit can't be obtained, because there are some patients who can't do it because of various different reasons, we go back to what we used to, so using our clinical local guidance and national guidance in order to assess that risk. And that flowchart on the right hand side is quite helpful. So quite clearly, if the fit test come back and it's 10 or more, you refer it down a 2-week wait colorectal pathway. But if it's less than 10, and one needs to consider if there is ongoing clinical concern and safety netting that patient appropriately. So there may be a number of other reasons that the patient has these symptoms, and it's helpful to cast a slightly broader net in what may be going on. If you are still worried about a cancer, and that cancer you are worried about is colorectal cancer, but the fit is less than 10, you can still refer down that 2-week wait pathway. If you're worried about cancer, the fit is less than 10, but you're not sure where that cancer may be coming from, your local non-site specific RDC may be the best place. The other thing you can do is use advice and guidance. The other thing you can do is watch and wait that patient and consider other general medical issues, such as IBD, infective colitis, or whatever may be going on in that patient's presentation. So there is a host of things and options that can be done, but one does not have to automatically exclude a referral on the basis of fit testing alone. So on the next slide, really basically just gives us an overview of what's available in North and Southwest London in terms of advice and guidance. In Northwest London, we're moving towards Vantage Rego, and in Southwest London, we have ERS, and that advice should be provided within 3 working days within your local from your local colorectal team. And if there are any issues about that locally, please do raise that with your borough lead, but can be incredibly helpful in troubleshooting issues. Next slide, please. This is just a really small snapshot from an audit that was done within Northwest London at the Imperial Trust, where the Colorectal CNS had a look at the number of patients that were referred in the month of November last year. And within 215 patients, we were really trying to help find out the number that were referred without a fit test and those that were referred with a fit less than 10. Interestingly, those that had didn't have a fit test or fit negative didn't have colorectal cancer, but it helped us look locally with our practices to help educate that the importance of doing this. Having done a fit test before referring a patient also helps that straight to test nurse to consider what next test is most appropriate, and that may be a CT pneumocolon or a CTVC, or it may be a colonoscopy. And if they don't have that result, it may add extra delays and diagnostic delays in that patient pathway. Next slide, please. Now, I'd encourage you to maybe go back to the Northwest London webinar link, which we've put, which is on YouTube and we can circulate around, where our expert, Mr. Al Myers, who's our pathway group lead for colorectal cancer, talked about this in a bit more detail. But there is data here about the importance of use of fit in rectal bleeding. Now, sometimes if a patient presents to us with rectal bleeding, you may think, well, do I really need to do a fit test because it's going to be positive anyway? And I guess on a case-by-case basis, this would be helpful to break down. But the data would suggest that patients with rectal bleeding that have had one-off rectal bleeding and subsequently have a negative fit, we can be reassured by that. But please do have a look at that webinar, and it would help break that down a little bit more. So next slide, please. And then the next slide. So we've got some top tips for practices and PCNs to help follow, and that would be fulfilling the DES requirements. And we've kind of talked about this in length before, and your borough leads will be talking to you about it, but it's helpful sometimes to think about your local data collection systems. And so you may want to undertake an audit and look to see how a fit test is being used. And we did, and an example of that was on a couple of slides before. We talked about how the number of fit tests were being ordered in a local geography of practices to Imperial NHS trusts. Tracking all fit tests and looking at who's initiated those investigations and test results, and those, are they appropriately used and tracked appropriately? There are already systems in place, so see the signs in Northwest London and Ardens within Southwest London, which can help do this, and having systems to document and ensure that all staff are involved. Engaging with your primary care team and primary care staff to raise awareness of it is very helpful and very important. And this is not just clinical staff, but also we know that the key, and there are key members, non-clinical staff, and also the allied healthcare professionals within our primary care teams that can really help make every contact count within primary care for our patients. And we may want to develop some PCN level systems to monitor that implementation, and that would be really helpful to make sure that we've got robust pathways and safety netting in order to do this and deliver on this. Next slide, please. Brilliant. So we've gone back to the national team, and we've looked at recording for the IF indicator, and we talked about this being within 22, 23, having a fit test done within 7 days of referral or 14 days afterwards. Now, GP practices are required to code and to put the SNOMED codes, which we've put in below, once the result is received from the pathology lab. So the pathology labs will deliver a read code, and within our own System 1 and EMIS we have SNOMED codes, and we're in the process of trying to identify within South and Northwest London if there is a way to automate this to avoid any manual coding, and we will circulate that information within our comms piece. But to track fit delivery for each 2-week rate referral, the SNOMED code is actually really helpful to indicate that provision of a fit test. And so if you go through those bits below and use those SNOMED codes, that's really the way to do it. Brilliant. Next slide, please. So this is just a little bit of extra information on AccuRx, and Maria, correct me if I'm wrong, but in Northwest London we use AccuRx a lot. Is it used in Southwest London?
Yeah, we use it a lot, and this is up and running, the reminder. So the patient gets a message straight away, and then a subsequent one 3 days later, just to make sure they bring it in ASAP.
Awesome. And those of you that are not familiar with this, just have a look at the useful information on that is on those links once we send the slides around. So those step-by-step introductions of what the messages are, and there is a video there as well about the pathway. But I think we're all quite familiar with the using AccuRx and sending out those reminders. Brilliant. Next slide. So this is just a very quick reminder of the colorectal pathway, and it just helps sometimes put in context what happens really after we initiate that referral. And we've talked a bit at the beginning already about undertaking fit for the symptomatic patients, and then once we may use decision support tools in order to help us generate that referral via ERS or Advantage Rego, and then once that referral is done, that's received within secondary care and then booked into sometimes a straight to test nurse appointment where they will look at the referral. Now, at that point of triage with the nurse, there are a couple of things that are quite key. So one would be having a renal function or iron studies may be helpful. So they'll be looking back, particularly if they're thinking about doing a CT colonoscopy. And so doing something contrast enhanced, you would need an up-to-date renal profile. So if that is there and available on the referral form, makes it easier. Issues with performance. So at that point, also the nurse will be looking at performance status to be seeing is that patient going to be, how do we present that patient at the MDT, and what would they be fit to come in, and anything about language, transport, and practice bypass numbers and emails are incredibly helpful. So these things that we can really help with that pathway by having those blood tests up, the fit tests obviously, the explanation of why they've come in, and those extra bits of information about transport, translators, interpreters, and if there are any particular learning difficulties or mental health issues within this patient population that you're referring, please make it clear on the form. So once that triage is done, using the algorithm that they use and their clinical decision making, that patient may go on to have a colonoscopy or a CT, and within 28 days of referral, which is the fast diagnosis standard, there is a target to make a decision and inform the patient of whether cancer has been diagnosed or not, if you see what I mean. So that's generally the pathway. And on the final slide, we've just got some information of resources to support PCNs with for colorectal cancer, and a little bit around fit testing. I think probably what I would encourage is just understanding locally your fit test supply and provision. Make sure that that's all in place. Thinking about what you do locally for those patients that are fit less than 10, and think about what we talked about with those guidelines. And also thinking about how you could audit any gaps that you may see within that pathway, within the colorectal pathway, from patient presenting locally to referring on. That I think those would be incredibly helpful, and also thinking about the data behind fit in the use of fit in rectal bleeding. something that I found incredibly interesting. Maria, is there anything else that you wanted to add on at this stage?
It was just to let you know that there is a question in the chat from Dr. Katecha. Where does direct access investigations fit in? There's a big political agenda to push this process. To me, it seems a little disjointed pathway compared to the TWR referral, but be interested to see your thoughts. Thanks. I know in South West London, we don't have direct access colonoscopy. We just have sigmoidoscopy. And so I've always gone down the 2-week wait pathway. I didn't know if you knew anything different, Abs.
Yeah, and in North West London, exactly the same. And I think probably the most important thing here is that if you are worried about cancer, there's a patient with a FIT of 10 or more, or you're worried about cancer and it's lower GI, that patient should be referred directly down a 2-week wait pathway for a specialist assessment rather than direct access endoscopy. And I think that's the best thing for the patient and the best thing for us to be able to take on. When it comes to locally within North West London, if we want to get an endoscopy, it's going to be on a benign pathway, and that would be through advice and guidance. And so we would have to go through the trust initially and speak to a specialist, and that patient can then be triaged onto a direct, and in particular trusts can be triaged to having a routine endoscopy. But in the context of cancer or suspected cancer, this patient, I think, is generally should be referred down a 2-week wait pathway. Ray, you're nodding. You same within Southwest.
Yeah, no, I totally agree.
Was there anything else in the chat box? Because as you can see, my tech's not up to scratch today.
No other questions. So if anybody does have anything further they want to ask, perhaps you could put your hand up. Oh, hang on, one more. Any advice if no response to advice and guidance within 3 days? During our gynae webinar, it was advised if no reply in 7 days to refer. Is that the same for all advice and guidance pathways? Actually, that's a really good question, because I'm in South West London and I'm so used to using Kinesis, and they're supposed to get back in touch within 24 hours, and we handily get an email to say that we've had a response so that we can go and check our own login. I'm not as familiar with advice and guidance. I've only just started using it, and I do find it a little bit clunky, and I don't know how we get advised that we've got a response, or whether you have to keep a note yourself and keep checking it. I'm not particularly au fait with advice and guidance. Have you used it a lot, Abs?
Yeah, so we used ERS advice and guidance quite a lot within North West London, and moving towards kind of Vantage Rego now, and we'd have somebody at the practice who would be monitoring ERS and would get a response and alert, and then would inform the most appropriate clinician thereafter. So whoever made the kind of AAG request to say, look, this was the response, and if there was something a little bit more urgent before that clinician comes back, if they work only a day or two a week, it would go to the duty doc or somebody else. And so we have local processes. I don't know if that's the same across the whole of North West London, can't speak to that, but yeah, so that generally speaking, that's the best way. And I think it is patchy depending upon provision. So the question about what do you do if you don't get a response, well, I think if you are worried about that patient, you're worried about cancer, well, I think in order to avoid diagnostic delays, you should refer that patient. I think within the I've done it before where I haven't got a response, and it was a slightly tricky referral, and I spent a bit more time on that referral, and I explained within that text box to say, look, I've tried to contact you via advice and guidance. I haven't got a satisfactory response. And so I think the more we feedback, the better we can make this pathway for our patients. If we are thinking advice and guidance, and you're not, I guess, as a clinician within primary care, we're a bit uncertain and we're not 100% this patient needs to go down a TWR. So what we want to do is avoid any unnecessary referrals and improve that patient pathway, so there's much feedback as we can do to secondary care as possible is best. So I'd put it on the referral form. I would also try and feedback to the secondary care, if in the context of colorectal cancer, it would be to the trust and their lead. And sometimes you can make these alerts. If you're finding that this is happening all the time, this needs to be highlighted through your kind of local channels, and that if you're not sure what that is in the context of cancer, please kind of flag it with your borough lead, and then we can find out if we don't know the answer. Okay.
So no more questions in the chat unless anybody else has anything else to ask. Please raise a hand.
I guess we've covered a couple of very important topics, and so thank you for those. Thank you for that. Thank you for everybody for coming and attending today. It was, I think, the first time we've put a North and South West London one together, so it was actually quite nice to do this together. We've put, Stevie will be sharing, and you may have done this already, the survey within the text, within the chat box. So please do take your time to be able to do this. It really helps kind of inform future webinars, and take the time to maybe look back if you have any specific specialist questions about colorectal cancer on that Northwest London webinar, because Al Myers really did that very incredibly well. And we will circulate the slides appropriately.
There's just one more question just snuck in there from Dr. Meshi. Should we do a fit test in elderly people with anemia? I think that really has to be kind of decided on a case-to-case basis, really, doesn't it? It depends what you mean by elderly. I mean, age in itself shouldn't be a reason not to do the test, but it all depends on their performance status and whether they would be fit for investigation, whether they want to be investigated or want to be treated if something untoward was found. So I think it really does depend on the patient. Would you agree?
Yeah, absolutely. I mean, I'd have a conversation with the patient and I'd see if they've got any lower GI symptoms, and if it is an iron deficiency anemia, make sure we've done our hematinics and our full iron profile. And then if you're worried about an unexplained iron deficiency anemia, and you want to investigate this and the patient does too, then yes, and a fit may be appropriate. But I guess there is a lot of that, and it's very hard to generalize it. Great. Okay. Well, I think it's now 2 o'clock. And thank you all for coming, and thank you for your time. And we will circulate these all very soon. Please fill out the survey. Thanks, Maria. Thanks so much.
Bye.